Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we shall discuss the clinicopathological profile of NAFLD and NASH. We shall discuss in this lecture that what is NAFLD, what is fatty liver, what is its pathophysiology, and what is the difference between NAFLD and MAFLD, what is the clinical profile, and what is the pathological profile of patients with NAFLD, and how these two are correlated. And this will help us in understanding the possible targets of intervention of treatment of this NAFLD disease. So as I said, topic for today's discussion is clinicopathological profile of NAFLD and NASH patients. This lecture gives the core concepts of the problem what we are facing worldwide. What is NAFLD? What do we mean by NAFLD? In simple words, this is the qualitative and quantitative change in hepatic fat content. There's a change in the fat content of the liver qualitatively as well as quantitatively, and this is NAFLD. So for NAFLD, you need qualitative change as well as quantitative change. If there's only qualitative change or quantitative change, it will not fulfill the criteria of NAFLD. So in NAFLD, the normal liver, it is replaced by the fat content. At least 50% of the weight is because of the fat. In normal liver, the fat content is 5 grams of lipids per 100 grams of weight of the liver. And out of this 5 grams per 100 grams, 64% is phospholipid, 14% is triglycerides and free fatty acids, and 8% is cholesterol. But if we see the fatty liver, for fatty liver, the fat content is increased by 10-fold. So this is minimum 50 grams of lipids per 100 grams of weight. So this is the quantitative change, that from 5 grams of lipid per 100 grams, it is increased to 50 grams. So this is the quantitative change, that the quantity increases 10-fold at least. And the qualitative change is that now more than 50% of this fat consists of triglycerides. It was 64% phospholipids, and in the normal liver, the concentration or the content of the triglyceride is 14% of this 5 grams. So in fatty liver, it is 50% at least or more than that of the total fat. So basically, this is the huge accumulation or huge deposition of triglycerides in the liver, which makes it a fatty liver. To understand, this is the normal liver. The blue is the triglycerides. The brownish is the phospholipids. The gray is the cholesterol, and the orange is the free fatty acids. While in fatty liver, the blue bar has increased. It consists of more than 50% of the liver, the triglycerides. The phospholipids, it's reduced. Same is the cholesterol and free fatty acids, which remains almost of the same. So the phospholipids, it is replaced by the triglycerides in a fatty liver. What is the pathophysiology? So many mechanisms have been suggested and considered. The first hit therapy, the second hit therapy. I will simply share with you only one slide, and it's a simplified mechanisms of the pathophysiology which was published just in 2021 that NAFLD and MAFLD, what is the pathophysiology, and it's very simple. That there are three main mechanisms. One is the genetic predisposition, like PNPLA3. And then there is diet, which is high in carbohydrate and fat. So the genetic factors, glucotoxicity, and lipotoxicity, these three play a pivotal role in the pathophysiology of a fatty liver, and they convert the fatty liver, the normal liver, into a fatty liver. The high carbohydrate or high fat diets contribute to the effect of glucotoxicity and lipotoxicity in the development of hepatic steatosis. Hyperglycemia and dyslipidemia induced hepatic insulin resistance and inflammation through different mechanisms in the NAFLD. These are the different mechanisms, the macrophages, their activation, production of the pro-inflammatory cytokines in different pathways. But there is genetic predisposition, and then there is hyperglycemia, and there is this dyslipidemia, and it leads to insulin resistance. And the first manifestation of insulin resistance in any person is fatty liver. And then later on, if no intervention is done, then the other features of insulin resistance and metabolic syndromes, they appear. What is the clinical spectrum of a NAFLD patient? It's got 4 components at least. The yellow is the fatty liver. If a patient develops fatty liver, by that I mean if the liver fat content is increased tenfold, and mostly this is triglycerides, and so we see the macrovesicular steatosis in these patients. Then a segment of these fatty liver patients, they progress into NASH. So the next step is NASH, which is the macrovesicular steatosis with steatohepatitis. We are aware of the hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E. This is the steatohepatitis. It's also an inflammatory condition. And this is induced by the fat accumulation. Then, out of these patients, they develop fibrosis. So it is a steatohepatitis with bridging fibrosis. And at the end, what happens? Cirrhosis develops. So it's a steatohepatitis with cirrhosis. So the NAFLD patients may fall into any of these 4 categories. Either they will be having simply fatty liver, or they may have developed NASH, or they may have fibrotic liver, or they may have a cirrhotic liver. But remember, the mammillary bodies in hepatocytes are pathognomonic of the NAFLD. NAFLD occurs at equal rates among males and females. The majority of cases are found within the 4th or 5th decade of life, although the full spectrum has also been described in children. The most frequent symptoms are fatigue and right upper quadrant pain or dullness, although many patients have no symptoms. Mild or moderate hepatomegaly is one of the most common physical examination findings. Unfortunately, there is no good correlation between serum liver tests and necroinflammatory activity or stages. Patients with NAFLD are often obese and may have hypertension and other components of metabolic syndrome. Biochemically, most of the patients with NAFLD have reduced insulin sensitivity, resulting in hyperinsulinemia, hyperglycemia, and hyperlipidemia. This is a recent review of a systemic review of NAFLD-associated extrahepatic disorders. And what the authors have concluded that patients with NAFLD and NASH may have early atherosclerosis, early cardiac structural and functional abnormalities of hypertension. I said mostly this is the full-blown NAFLD is the 4th or 5th decade disease, but in youth also it can happen and can lead to these two. Pre-diabetes condition and type 2 diabetes. Then it can lead to decreased bone mineral density and osteoporosis, polycystic ovary syndrome in females, reduced GFR and macroalbuminemia on the kidney side, and they are obese and they may suffer from obstructive sleep apnea. So this is the extrahepatic organ damage in NAFLD, especially in youth patients. Just 30 seconds on the metabolic syndrome, because this is important to understand the metabolic syndrome while discussing the clinical features or clinical profile of NAFLD. Any three of the followings will make a diagnosis of metabolic syndrome. What are these? Waist, if the waist circumference is more than 34 inches in men and 32 inches in women, this is in Asia, this will make one criterion of the metabolic syndrome. Globally, it is 40 inches in men and 35 inches in women. Second is diabetes. If a patient fasting blood sugar is more than 100 milligram untreated, or if the patient is on treatment, so even if normal fasting blood sugar will make one criterion for a metabolic syndrome. Then hypertension. If the blood pressure is more than 130 by 85 millimeter, or the patient is on treatment for hypertension, this makes the third criterion. Fourth is high triglyceride levels. If the TG level are more than 150, or the patient is on treatment to make the TG levels normal, this is the fourth criterion. And the fifth component is low HDL cholesterol when it is less than 40 milligram in men or 50 milligram per DSL in women, as if the patient is on treatment. So out of these 5 criteria, if any 3 are present, this will make a diagnosis of metabolic syndrome. For example, if a patient has got increased waist circumference, patient is diabetic or hypertensive, the patient is metabolic syndrome patient. If the patient is thin and slim, but the patient is diabetes, hypertension, and high TG or low HDL, again, the patient qualifies for the diagnosis of metabolic syndrome. So this is important, especially when we are discussing the NAFLD patients. So NAFLD to MAFLD, it's a redefining moment for fatty liver disease nowadays. And when you will go to literature on NAFLD, you will see the words MAFLD. So I will try to explain what is this NAFLD and MAFLD story. NAFLD, we know it stands for non-alcoholic fatty liver disease. NAFLD is defined as the presence of hepatic steatosis in patients without excessive alcohol consumption, concomitant liver diseases, are secondary causes of fatty liver. On the other hand, MAFLD stands for metabolic associated fatty liver disease, and MAFLD is defined as the presence of hepatic steatosis in patients with one or more of the followings. And what are these? Type 2 diabetes, overweight or obesity, and 2 or more other metabolic risk abnormalities. So the conventional NAFLD, it excludes all these causes, while the MAFLD, it includes these 3 factors. So this is the difference between the NAFLD and the MAFLD. So to summarize, if there's a fatty liver, if there's hepatic steatosis, whether this was on ultrasound or on serological scores or liver biopsy, if the patient has got hepatic steatosis and the patient is type 2 diabetes, automatically this will be called MAFLD. If patient is with hepatic steatosis, is overweight or obese, the BMI is more than 25, and in Asian more than 23, again, this will constitute the terminology of MAFLD. This is not NAFLD, this is MAFLD. But if a patient is lean with normal body weight, but hepatic steatosis is there, then we will go for the at least 2 out of these 7. So if the lean or normal weight patient with fatty liver has weight circumference, or the patient has got blood pressure high, or TG high, or HDL low, or the patient is pre-diabetic state, or the patient has got the homeostasis model assessment of insulin, HOMA score more than 2.5, or plasma high sensitivity C-reactive proteins more than 2. So a lean, normal weight person with hepatic steatosis. So if any of these 2 are present, for example, CRP is raised without other cause, or HOMA score is raised, or the patient is diabetic or hypertensive, or the patient HbA1c level is high, this will make him or her as a MAFLD patient. And why this is important, that you should be clear whether our patient has got NAFLD or MAFLD. I'll explain this in the coming slides. So the terminology of changing from NAFLD to MAFLD involves not only a change of name, but also of disease definition. Does it really matter that we should be clear whether our patient is NAFLD or MAFLD? Yes, I'll share with you the details or the study or the data of 2 studies which were published recently. This study in August 2020, issue of Liver International, Lin et al. Compared the characteristics of individuals with MAFLD versus NAFLD in more than 13,000 subjects from the general population who were enrolled in the 3rd National Health and Nutrition Examination Survey of the United States. So he compared the patients with NAFLD and MAFLD, and these were 13,000 subjects. And what he found, that these 13,000 subjects, they fall into 2 categories. One, those who are neither having fulfilling criteria of MAFLD or NAFLD, and they were 58%. The 42% of patients, they had either fulfilled the criteria of MAFLD or NAFLD or both. Out of these 42, almost 34%, they were fulfilling criteria of both. And in this series, around 4.7%, they had the criteria fulfilling for the NAFLD, not for MAFLD, and 2.6% they fulfilled the criteria of MAFLD, not for NAFLD. Don't get confused, I'll explain to you in a while. Then another publication just last year, again, they had the same observation and shared the same data. If I conclude what the authors suggested from their review articles and the studies, review of the characteristics of these patients, then they said that if this is a NAFLD patients, as shown by the yellow strip, and these are the MAFLD patients shown by the green strip, what they said that around 80% of these patients, they were fulfilling the criteria of both NAFLD or MAFLD. It was only 20%, and out of these, either 10-15% on one side and 10-15% on the other side, who were not fulfilling both criteria, who are fulfilling either criteria of NAFLD or MAFLD. In other words, we should be clear, or we should, that if a patient is NAFLD, the patient is MAFLD case, the patient has metabolic syndrome unless proven otherwise. And this is important. When see what they found what they reported the features of these groups. This is those patients who are not fulfilling criteria of NAFLD or MAFLD, or those who are not having any NAFLD or MAFLD, and those patients who are fulfilling criteria of NAFLD only, and this column is for those who are fulfilling criteria of both definition NAFLD or MAFLD, and then this column is for those who are fulfilling only criteria of MAFLD, not NAFLD. It means there are risk factors. So the steatosis, obviously it was absent in the non-NAFLD, non-MAFLD group, while it was present in the rest of the three groups. Coming to the age, the people in the non-NAFLD, non-MAFLD, they were younger. Also, patients with NAFLD, they were younger, and only in the MAFLD, they were younger, but they were having the risky behavior of alcohol, or they were alcoholic. It was when the NAFLD and MAFLD both criteria was fulfilled, these people, they were older than these others too. So age is one of the risk factors. BMI, it was lower in NAFLD, and it was higher in NAFLD or MAFLD, and highest in the MAFLD. Then alcohol consumption, it was especially seen in MAFLD patients, not with NAFLD and MAFLD. ALT levels, they were normal to high in NAFLD, but in the other two groups, they were higher. So in NAFLD, we may see normal ALT, but in other two, the ALTs levels were high. Fibrosis were absent to less. Fibrosis in non-NAFLD, non-MAFLD group, while in NAFLD also it was less. In MAFLD also it was less, but in NAFLD, MAFLD, this was higher. So the features of metabolic syndrome speeds up the deposition of fibrosis in this patient, and this is important. Metabolic picture or profile was better in the non-NAFLD, non-MAFLD patients, and this is obvious. It was better in NAFLD as well. It was better in MAFLD as well, but when it was combined with the NAFLD and MAFLD, then these patients had very high comorbidities. Similarly, risk of cardiovascular diseases was higher in NAFLD, MAFLD group as well as in the MAFLD group. So this was the difference between different clinical features of NAFLD or MAFLD patients. So the clinical implications of this change of NAFLD to MAFLD is that majority of patients with fatty liver fulfills the definitions of both NAFLD and MAFLD, but 10 to 25% meet the criteria of only NAFLD or MAFLD. Presence of metabolic risk factors is mandatory for the diagnosis of MAFLD, not for the NAFLD. Some patients having lean NAFLD, by that I mean normal BMI, may not fulfill the criteria for MAFLD. Patients with hepatic steatosis who were previously classified as not having NAFLD due to alcohol consumption, and that is more than 30 grams per day in men or more than 20 grams per day in women, other liver diseases or secondary causes of fatty liver may nevertheless be diagnosed with MAFLD. So no, we will include those patients as well. And MAFLD improved the detection of patients at higher risk of liver and cardiovascular comorbidities. So after these fatty liver group, if we include the MAFLD features, the metabolic syndrome features, then we can detect that those who are at the risk of these diseases. Now coming to the second component, that is what is the histological spectrum. There are four types of NAFLD patients. When the patient has only macrovesicular steatosis on pathology, on biopsy, this is called type 1 NAFLD patients. But when they have the macrovesicular steatosis as well as steatohepatitis, if both these features are present, this is called type 2 NAFLD. So in type 1, only macrovesicular steatosis is present, while in type 2, macrovesicular steatosis as well as steatohepatitis is present. Then, if on the top of these two, macrovesicular steatosis, steatohepatitis, if there is cytoplasmic ballooning, this will make the patient is type 3 NAFLD. So the three components, both three, they are present, and this is type 3. If there is medullary bodies as well, so macrovesicular steatosis, steatohepatitis, cytoplasmic ballooning, and medullary bodies, so this is type 4 NAFLD A, type 4 NAFLD A. And when there are bridging fibrosis as well, so this makes complete picture of type 4 NAFLD. So depending upon these four components, as the another component is added to the clinical, the pathological or the biopsy results, the NAFLD grade is increasing. Type 3, that is patients with macrovesicular steatosis, steatohepatitis, and cytoplasmic ballooning, and type 4, meaning patient with macrovesicular steatosis, steatohepatitis, cytoplasmic ballooning, medullary bodies, and bridging fibrosis, it makes a patient, NAFLD patient, as a NASH. So if a patient with NAFLD, fatty liver, has all these 4 or 5 features, we will call this as a patient with NASH. And remember that NAFLD activity score is calculated by your pathologist. And in this score, 0 to 3 marks, that is 4 points, are given to macrovesicular steatosis, depending upon the severity. Then 4 marks or points is given to the steatohepatitis, depending upon the severity. And 3 points, 0 to 2, are given to the cytoplasmic ballooning, depending upon the severity. And the total score, if it is more than 3, and at least 1 point should be from the ballooning injury, then this will give the minimal criteria or histological criteria of saying that this patient has got NASH. So this is important. So this was for my younger colleagues, that how to interpret the biopsy report of a NAFLD patients, whether the patient has got type 1, type 2 NAFLD, or type 3, type 4, which will be called NASH. How these are correlated? The type of the NAFLD and clinical correlation. The type 1 NAFLD patients, where there is only macrovesicular steatosis, it is known to be non-progressive. The type 2, which are having steatosis as well as steatohepatitis, this is probably benign, and it's maybe considered as a mild form of NASH. So cirrhosis may occur only in 1 to 3% of patients with steatosis alone, but particularly in the presence of metabolic syndrome. So if a patient has got metabolic syndrome, and if the patient is having either type 1 or type 2 NAFLD, still the patient may develop cirrhosis. So that's the reason I'm saying that we should look for the features of metabolic syndrome in all fatty liver patients. Type 3, so NASH without fibrosis, it may progress to cirrhosis. And type 4, NASH with fibrosis, does progress to cirrhosis and liver failure. So cirrhosis develops in 9% to 25% of NASH patients. So almost 1/4 of these patients, 1 out of 4 develop. Once they develop cirrhosis, 30 to 40% of these die over 10-year period. So very progressive course. 8% of the patients, they will develop HCC. So in the days to come, in the years to come, the main cause of HCC, I'm afraid, is going to be NASH. And this is going to be the #1 indications for liver transplants in Pakistan as well as across the globe. So to conclude, my dear colleagues and PGs, there's a qualitative and quantitative change in the fat content of the liver, which makes the definition of NAFLD. Normal concentration is 5 gram per 100 gram of body weight, while in fatty liver it is 50 gram at least, and more than 50% of this is triglycerides in fatty liver. There are three main mechanisms. One is genetic predisposition of a patient to develop fatty liver. Then there is glucotoxicity and lipotoxicity, and these leads to the development of insulin resistance and then other sequelae. Around 80% of the patients with fatty liver, they fulfill the criteria of the other definition of the NAFLD and MAFLD, and these are at the risk of developing cirrhosis and other consequences. By and large, fatty liver patients or NAFLD patients fall into one of these categories. Patient may be having fatty liver, NASH, fibrosis, or cirrhosis. And depending upon the pathological features, if it's 1, 2, 3, 4, 5, the NAFLD is classified into 4 types: type 1, type 2, type 3, type 4. Type 3 and type 4 is called NASH. The NAFLD activity score requires scoring the steatosis, steatopatitis, and ballooning features, and at least 3 score of 3 or more than 3 is required, and 1 point should be from the ballooning injury. As I said, type 1, type 2 are probably benign, but if there are features of metabolic syndrome, 1 to 3% of these they will develop cirrhosis, while type 3, type 4, they are aggressive ones. Cirrhosis develops in 9 to 20% of the patients, and once the cirrhosis develops, 30 to 40% of these they will die over 10 years period, and 8% of these cirrhotics will develop hepatoma. This is very important that we should be knowing the pathophysiology and management because the management options depend upon the pathophysiological stage. For example, in the normal liver, when fat is less than 5% of the hepatocytes, the current treatment options is that if you keep the liver a healthy liver, you avoid the injury to the liver. But if the patient develop NAFLD, means steatosis, fat in more than 5% of the hepatocytes, and the weight is 50 gram. So there's hepatic lipid reduction. You need to do that. You need to go for the weight loss. You need to go for the lifestyle modification, and this is totally reversible. You can push the patient from NAFLD to normal liver. Then if a patient develops NASH, it means steatosis, inflammation, ballooning, and fibrosis. Then again, here you can intervene by the hepatic lipid reduction, weight loss, and lifestyle modification. Even people have tried here the vitamin E and the pioglitazone, GLP-1 agonist, SGLT2 inhibitors, and more than 5% weight loss. And when you do, you can push a patient from the fibrosis to the NASH. In fibrosis, there is late stage fibrosis. Then it's cirrhosis when there's diffuse fibrosis, severe damage of liver function, and hepatocellular carcinoma. So these 3 are mainly responsible for the liver transplant or deaths. So if you can regress the fibrosis by more than 10% of the body weight loss over 6 months, you hope that probably by the weight reduction and by the use of these different medical therapies, you may hope that you may push a patient into NASH and then onwards. But whatever drugs comes for the NAFLD, whatever modality comes, the pivotal role of lifestyle modifications, physical activity, and normal BMI, weight loss is the main reasons. Is this the main background? Unless the liver is free of fat, you lose weight, you adopt healthy activity, You cannot expect that the drugs which you will be giving to a patient will be doing any wonder, though it's very difficult. That lifestyle modification is the most difficult one. But we should be attempting. I believe that if persistent change in the body weight is there, then these drugs will be more effective as compared to the one when there is no lifestyle modification, there is no weight loss, and there is no dietary change, and you expect these drugs that they will do the wonder. I'm sorry, they will not. So with this, I thank you for your kind attention. See you in the next lecture on another topic. Till then, Khuda Hafiz.